I'm very curious to see how everybody in different countries around the world do it. Certainly within the US, it's a little bit more controversial, though I think it's becoming more standard with pancreas cancer being thought of as a systemic disease, and it is. Before you take somebody to the operating room, do you do a neoadjuvant approach? Do you do a neoadjuvant approach with just chemotherapy? Do you include radiation therapy? And then that way you get the treatment in. So 50% of patients don't get adjuvant therapy. This way they get it beforehand. So Winson, tell us a little bit in Canada what your approach is to these patients that come in, even with resectable disease.
Neoadjuvant therapy is probably used most extensively in the borderline resectable. If they're clearly resectable, I think that the trend is still to have them proceed to surgery right away. Although, as you mentioned, it is quite controversial, and there are some surgeons and oncologists who would favor a neoadjuvant approach. So that's kind of the extent of its use. It's not used very, very heavily at all, actually.
So in these borderline patients, what's your approach? Which chemo do you use? Do you use radiation? Do you use it all? Do you?
Yeah, so radiation, again, not very much. And in terms of the decision between FOLFIRINOX or GemNab, it again comes down to the patient's performance status. So if they're very, very young, fit, compliant, then there's a tendency to use FOLFIRINOX, and vice versa. If they're a little older, a little less fit, then usually favoring a GemNab. Again, we've read our local experience, and the rate of downstaging, for example, is actually very, very rare. So again, it kind of calls into question whether there's a true role for neoadjuvant until a trial proves its efficacy.
Very interesting. Manuel, what do you guys do in Boston?
So if it's a clearly resectable patient, is resection followed by chemotherapy. Borderline and locally advanced, we classify them, but we manage them the same way, with the difference that locally borderline is going to go to surgery unless there is progression, right? Because they are technically resectable if you do vascular reconstruction. So they're technically resectable, and they're going to be resected. Usually they get chemotherapy, FOLFIRINOX or GA. Then you have a first look. If downstage, sometimes they go to surgery early. Otherwise, SBRT, followed by more chemo, and then surgery. So, but you do surgery. You have, in the course of the 6-7 months, surgery occurs often at the end. And when you get, I mean, the median survival of these patients is in the 22, 23 plus months range, and you get a fair, decent 60-70% margin-free resection in the true borderline. Now, locally advanced is the same management, but surgery is an exception.
Yeah.
And I think that the LPAC data of 30% in our, I mean, I don't know the numbers, but I think it's a little bit lower, the patients that are able to be
It was
operated.
about 15%
15%.
in the study.
15%.
Which you know, falls around.
15% is more.
15% is more.
They may have taken more patients. I think you did in this. I think they've taken more patients than they've resected.
I think 30% may have been explored, and 15% had.
So half of them end up.
Now, locally advanced is also a spectrum.
Mm-hmm.
So the real T4 tumors with celiac trunk encasement, those
Forget
I would
about
say
it.
never go. The tumors are classified because there is more than 180 degree of SMA. That's a different story because they can do vascular reconstruction.
Yeah.
So these are two very different groups with regards to surgical potential.
All right, I can't wait to hear what the Germans do.
In our system, it's a bit difficult a bit more different because our surgeons are a little bit more aggressive, and in our guidelines we define borderline different because venous involvement will not count as borderline but clearly resectable because they say data outcome is the same, so why should we differentiate? And I'm running a trial in Germany, a multi-center trial on neoadjuvant treatment of clearly resectable with Gemabraxane in this case, and there is a good rationale for doing that, for neoadjuvant treatment, but it needs to educate surgeons that this is a sensible idea and you shouldn't resect straight away. And of course, we don't have the data to do it out of a trial. I think we need to run the trial, and we need to tell patients that 20% of patients will progress under neoadjuvant treatment. And there is a debate that surgeons say we could have saved this patient, and I say this is the patient who should not have been operated in the first place, and we select those who actually will not benefit. So this is for the clearly resectable. For the locally advanced, we're running 2 different trials. One is a chemo trial where we actually have FOLFIRINOX plus gemabraxane in exchange in these patients. And when they are actually stable or downsized on imaging, they need to be surgically explored. It's compulsory because I think imaging lets us down. When we decide on doing an aggressive treatment, and chemotherapy is also an aggressive treatment, then we need to explore them surgically. And we have another trial running where you have a chemo induction in those who are stable, then undergo either radiotherapy or chemotherapy in locally advanced disease, and then they get surgically explored if they are still stable. But bearing in mind, the radiochemotherapy in locally advanced disease, even when you're talking about SBRT, we're saying, well, now we have more aggressive protocols, but we don't know, I think, because we have better chemotherapy protocols, and that may actually completely obliterate an additional effect of radiotherapy. We don't know. So we can see it both ways, and I think we need to do it in trials. This an automatism where you say, well, it's locally advanced, let's irradiate. That's something we don't do. We will do it to control pain, but this is not in a high proportion of patients where you really need to do that for pain control, but not as a standard. And I think we need to run the appropriate trials, also with more modern radiochemotherapy schemes, more better planning of radiation treatment. Maybe SBRT works, but it's not done at very many sites in Germany because it's toxic. You need to really be very, very precise in your planning, and it needs a dedicated radiotherapist. So you need to have somebody who loves doing pancreas. There are not that many, particularly in Germany because it's not so popular. But there is some potential, but it's not standard, definitely not standard for us.